And let me invite Dr. Praveen Muraly to give his top 10 messages in the management of diabetic macular edema. Praveen Muraly is consultant vitreoretinal surgeon at the Eye Foundation Hospital, Cochin.
Thank you, sir, and I thank KSOS to give me this opportunity. So from the previous lecture, we already know that it's an epidemic, and as the epidemic rises, the incidence of diabetic macular edema will increase, and the most common cause of moderate visual impairment among people with diabetes is DME. So today's talk is on top 10 messages in the management of DME. I'll go in stepwise, where we first start with the history. So the duration and control of DM is very important. So each time a patient comes to you, this is should be insisted, ask for HbA1c. If we keep repeating this every time they come, at least we take the first step towards the control of diabetic mellitus. Along with that, the systemic comorbidities also can be asked, like hypertension, hyperlipidemia, anemia, and renal disease. Second is the visual acuity. The best corrected visual acuity should be taken. This not only helps to help in assessing the progression, also to see for the treatment response also. When we come to examination, have a good look into the eye, see the pupils nicely, see for the margins of the pupil, to see for NVI, NVAs, check for IOP, see for the how the pupils are responding to dilatation. And then go ahead with dilatation and see the fundus with both 90 diopter or 78 diopter lens, or a 20 diopter lens. FFA as such, the role has become very less in case of DME. However, you can classify, once you do an FFA, into focal and diffuse. Most important is to see for macular ischemia. So what you can see in this is not just enlargement. More than that, just see for notching. Any notch can suggest in form of macular ischemia, or you see for any aneurysms at the edge of the FAZ. So that also can signify macular ischemia. With the advent of OCT and anti-VEGF, OCT is now widely used and is the most common imaging tool used by all of us, not only for diagnosis, however, even for prognosis and follow-up of diabetic macular edema. It has multiple poor prognostic factor, which when you see can tell the patient about the prognosis of the patient, and we can say that mainly whatever management we are going to do is for just to sustain the same vision. So features like drill or loss of outer integrity of the outer layers and all can be seen and explained to the patient. You can also see the tractional component, and if there, then we can suggest treatment accordingly. Coming to the management, at present we are divided basically into non-center involving or center involving diabetic macular edema. So when we say non-center involving, see the OCT image, the central grid is the central and the rest of the area are called non-central. The management varies. So when we come to the management, the non-center involving, you can consider as to observe. It's not a mandatory to teach such patient. Why so? Because the long-term study, whatever multiple studies we have, the progression from non-central to central is only around 15% over the year of over 1 year's time. So during this time, you can advise them to have a very good control, do an HbA1c, do for lipid profile, send them to a physician to have a good control of the systemic factor. And if needed, you can, this is one of the indication where you can do a focal laser. You can see those aneurysm, you can hit the aneurysm, you can even do an angiograph, see for those leaking aneurysm, and you can treat them simultaneously. For center involving, now with multiple trials, we know that anti-VEGF is like a standard for treatment for center involving diabetic macular edema. However, when you want to switch to steroid, or when you want to give steroid, they can be given in patients who have reached a plateau where there is persistent intraretinal fluid with multiple treatments, or if response to anti-VEGF is there, but sometimes the patient finds it difficult to have a follow-up. Patient requiring cataract surgery, you can give. Eyes where it has undergone a vitrectomy, long-term depot steroids are helpful. And in patient who had some vascular event like myocardial infarction, stroke, any thromboembolic phenomenon, they can go ahead with intravitreal steroids. When we consider surgery for patient with DME, so we can go ahead when there is a VMT, ERM, STOT, posterior head. These are the main indication. The role in recalcitrant DME is doubtful. A large series which had come recently shows not much advantage. So other than the traction which is released during the surgery, it also helps in other hypotheses which are given is it can help in better oxygenation to the inner retina, can improve the capillary blood flow, reduce hypoxic induced VEGF drive. So, last but not least, the most important thing is control of systemic factor. So keep insisting for all these patients about the glycemic control. So this is very important. Ask for HbA1c every time they come. Many physicians may not insist, many of them go to a general practitioner. So if we can insist again and again, because they will follow up with you every 3 to 6 monthly. So if we can insist over the period of time, they may realize the importance and have a good control. Along with that, other factors like blood pressure, renal status, lipids, they are all important. Have an evaluation and you can send to the physician for adequate control. Last, just few topics where you have a mix what to do. Like when you have a PDR with DME, you can either go with a anti-VEGF treatment plus or minus PRP as and when required, but don't just leave the patient with just injections. Cardiovascular event, I have already told that should not be initiated if it is within the 3 months period, but anything after that you can give, but always consult a physician or take the physician into the loop before going ahead with the injections. Sleep apnea is one thing which is not commonly looked into, so we can all try to ask for some history, and if it is there, treatment for the obstructive sleep apnea like CPAP has shown to stop or reverse DR and DME progression. And during pregnancy, the use of intravitreal anti-VEGF is not recommended because of the potential effects on the developing embryos on fetus. However, if there is a progression of progressive loss of vision, then you can consider intravitreal steroids, but should explain clearly about the possibility of cataract and glaucoma to the patient. Thank you.
Praveen, would you routinely advise FFA in your DME cases and your PDR cases?
So nowadays, with the advent of OCT, OCTA, the role of FFA have reduced significantly.
Even in your PDR?
One case where I feel it is indicated is asteroid halosis, where you can catch on NVs. That was the pictures which I had shown actually. It was with asteroid halosis, and you can easily pick up NVs clearly.
I still think of FFA in a after treatment, not before treatment for PDR. And if I have a larger wide-angle fundus camera, then I can take the peripheral areas where you can. OCT NGO right now is not really wide-angle most of the time, and it cannot get the subtle ones, very fine ones cannot sell. So those areas. Pre-treatment, PRP treatment, fluorescent angiography is most probably not required today.
Thank you, Praveen. Please.